الثاني الاستاذ الدكتور ماهر فؤاد رئيس المؤتمر هيتكلم على نيو ترندز ان immunosuppression فور رينال ترانسبلانتيشن.
برضه مش جاي.
لا مش جاي. Mr. Chairman, ladies and gentlemen, in fact, immunosuppression became والله أنا أشكر رئيس المؤتمر والسادة الشيخ وأشكر الأودينس طبعا والحضور It's pleasure to have all of us attending this 11th transplant meeting. الحقيقة أصبح من العلامات اللي هي الواضحة في البروجرام بتاع Egyptian Society of Nephrology.
ربنا يخليك لينا يا ماهر.
ربنا يخليك ليا أنت كمان. In fact, immunosuppression became a problem for us. A lot of drugs, and the choice sometimes is difficult. And I believe we have to put at least locally some guidelines and certain hot points how we proceed with our patients. And at the same time, this is not against a particular drug, but trying to find what is most suitable to our patients. The basic strategy of immunosuppression at any time, three main important points. High dose initial suppression, aiming at to facilitate graft acceptance, minimize early rejection, and favor induction of tolerance if possible. Second main point, it is main therapy for chronic acceptance of the graft. And at last, whenever there is a rejection, we have to augment our immunosuppression. This is illustrated in this drawing. In high-risk patient, we have a sort of induction, then high initial doses, start to lower until the third month, then maintain. The new paradigm now is thought to be followed. We have to individualize immunosuppression and at the same time to minimize immunosuppression according to a schedule, time schedule. The individualization is based on two main important points. That is, existing drug toxicities and the immunological risk. In fact, this immunosuppression rationale aiming at two main points. Too much immunosuppression will lead to cardiovascular disease, infection, malignancy, and nephrotoxicity. Too little will lead to rejection. And the target of this new paradigm is to reduce the side effects, to preserve the renal function, and decrease the risk of cardiovascular disease. Here, this shows how we planned our patient. We have the low-risk patient that is non-sensitized, Asian Caucasian, the elderly, living donor source as most of our transplants, good HLA matching, and these follow the minimization protocol. For the high-risk group, that is highly sensitized, non-primary transplant, second, third graft, African Americans, those with cadaveric transplants and poor HLA matching, we have to do a sort of induction, the triple therapy, and keep them at high dose. Why we minimize these immunosuppressive drugs? Both steroids and CNI always we claim that they are main source of this complication. And we usually puzzle which is supposed to go first, steroids or CNI. Both cause hypertension, diabetes, bone disease, infection, hyperlipidemia, and they have bad osmotic effect. CNI, or above that, they have the nephrotoxicity and the malignancy, and the steroids above that, we have the weight gain and eye disorders. And the preference of the patients usually prefer to get rid of steroids and to minimize CNI. The new trends now, we have to do induction, and there is indication for induction. We can't do it as universal to all transplant in our cases, especially we are doing HLA. It is an elective operation, and you have the choice and the proper HLA match. There is center indication that I will illustrate later. There is the steroid sparing and the steroid avoidance, and we shall explain that in details. And the third is how to reduce CNI after the critical post-transplant period. We can't minimize it too early. And at last, how to avoid it, and the role of mTOR inhibitors. And at last, single drug program that Professor Tariq Hussain will discuss the new drugs in the pipeline of immunosuppression. What is induction therapy? In fact, induction therapy, it is the use of biologic agent to induce some degree of tolerance to the allograft, blocking early T cell function and activation, and later reorient the immune response. And this will reduce rejection, facilitate introduction of calcineurin, reduce the dose of immunosuppression, and allow the use of sparing regimen later on. What are the induction therapy used? We have the monoclonal antibody, which is the most important at the IATG. The monoclonal antibody, Bezilamax and dapirolizumab. We have the OCA-T3, we have atezolizumab and anti-CD20, that is the rituximab. And moreover, we have the immunoglobulin intravenous. As you can see, the most commonly used is the thymoglobulin. It accounts for 34% of the people who receive the induction, followed by bezilamaximab and dapirolizumab, and 30% of the patient does not receive induction because it has certain indication, and we cannot make it as universal guidelines. Who should receive this induction therapy? Basically, a high-risk recipient. Who are the high-risk recipients? Retransplant, second or third, patient with high PRA, pediatric recipients, African American, long cold ischemia time, recipients of kidney from marginal donors, and out the renal transplant, that is pancreatic transplantation. Induction therapy, that is the ATG, it is produced by immunizing horses or rabbits with human lymphocytes, harvesting the IgG and removing toxic antibody. We have thymoglobin, ATG ferruginous, and the polyclonal ATG, the ATGA. In fact, the thymoglobin in meta-analysis is the only induction therapy that has been found. Besides decreasing the incidence of acute rejection, there is some studies showed that it may prolong the graft survival. That's prolong the lifetime for the functioning graft. The IL-2 receptor blocker, it is effective prevent binding the IL-2 receptor alpha to the proliferating T cells. Several antibodies have been discovered and assessed, and it can be used complementary to CNI calcineurin inhibitor. It has its complementary action. What about the campus? We have three preparations. The most important of these is the humanized IgG antibody. It is similar lytic activity to compass IgG, but less associated with development of anti-atypic antibodies than compass IgG. How it works, the atezolizumab, the compass, it is the humanized anti-CD25 that deplete T and B cells, lymphocytes, NK cells, monocytes, and macrophages, originally or initially approved to be treat B-cell chronic lymphatic leukemia, and later now can be used. They try to use it as induction therapy. There is a difference between depleting and non-depleting induction agent. The depleting one, rejection rarely happens during its use. Calcinum inhibitor can be delayed so long as depleting induction therapy are used, but there is acute side effects, increased incidence and infection and malignancy, but effective in delayed graft function, better results with high risk recipients. In non-depleting, we may have rejection during its use. CNI cannot be delayed with its use, but luckily no side effects, very safe, and not associated with complication of over immunosuppression. That is for induction therapy. The second important issue is steroid withdrawal, and the fight is early versus late steroid withdrawal, which is better and which is the proper timing for withdrawal if your protocol allow you to steroid withdrawal. Generally, steroids are used in transplantation for prophylaxis of acute rejection, and this is by its immunosuppressive effect, treatment of acute rejection by its anti-inflammatory effect, and prophylaxis of chronic rejection by its anti-proliferative and anti-inflammatory effect. However, the steroid use in solid organs declined or dropped drastically. As you can see, between 2000 and 2004, the use of steroids, whether in living donor, the red one, or the diseased donor, it started to decrease. Why we should stop steroids? Of course, to minimize the adverse effects without increasing acute or chronic graft loss. Because it increases post-transplant doses, it increases cardiovascular mortality. And the management of these side effects is definitely highly expensive. And it is the immunosuppressive drug with the lowest compliance. Many patients try to escape the dose of steroids, and this usually leads to acute rejection. The main two plans or main two protocols for steroid avoidance or steroid sparing strategy, either using low dose for some months, then stop, that is delayed withdrawal, or early withdrawal, that is sometimes called avoidance. We use the steroids only for just a week, which is better, and how to proceed. In fact, in considering steroid withdrawal, there is many variables that we should be considered. It is the timing. It is less than 3 months or more. What is the type or the maintenance immunosuppression protocol we are using? Are you using CNI with AZA, mycophenolate with sirolimus, or MPA? Whether you have induction therapy or not, and which type of induction therapy. Thus, these three main issues should be considered before your decision of steroid sparing regimen. For example, if we consider timing of steroid withdrawal, there is here late steroid withdrawal is consistently associated with increased risk of rejection. وفي هنا two studies هتلاقينا هنا كلهم الاثنين بيقول ان الاكيوت rejection اكتر, which is withdrawal is definitely worse, اوحش كتير من ان احنا نسيب العيان على السترويد. فليه السترويد is not recommended. قال له طيب هل الاميونوسبريسيف بروتوكول افكت الديسيجن؟ يس. مش هنتظر ما يحصل له اكيوت ريجكشن كلينيكالي بس هنحطه من خلال السب كلينيكال ريجكشن. And you can see that this is the red line that is the tacrolimus MF has the with steroid withdrawal it has the lowest instance of subclinical rejection. وأعلى instance of subclinical rejection when we use steroid withdrawal is the cyclosporin with AZA. But cyclosporin with MMF or cyclosporin with MF and the mycophenolate is in between. إذا the safest immunosuppressive protocol اللي يخليك يشجعك to withdrawal actually is tacrolimus with MMF. And that has been found in this meta-analysis that graft survival actually is marginally, if not at all, affected with the steroid withdrawal. But if I escape the increased instance of acute rejection in the proper selection of my patient, I will find that graft survival is not affected in this meta-analysis. By the choice, you can do so. Moreover, the level of cholesterol is definitely lower in these cases, considering one of the important issues that we have to follow is escape the risk factor of cardiovascular complications in our transplant recipient. What is the proper time? This study showed clearly that the hazard of graft loss is more or less the same so long as you are in the first 4 months, and then gradually increase, and it's highest if it is late withdrawal. After revising these variables, we can put this recommendation. Safe to withdraw with steroids if low immunological risk, using CNI and other MMF or mycophenolate or mycophenolate. With cyclosporin, more rejection had been found. With tacrolimus, no problem, but we don't have randomized control trial. This is personal opinion. There is improvement cardiovascular risk profile, no controlled evaluation after 3 years. This data is feasible for the first 3 years. Well, what about the steroid withdrawal in the first week? In fact, the Minneapolis study withdrawal. This study showed steroids were given for a total of 5 days. Besides prednisone 500 intraoperative, first day we give 1 milligram per kilogram of the weight, then half milligram for 2 days, 1/4 or 0.25 milligram for day 4 and day 5, then withdraw in the presence of cyclosporin or tacrolimus with MMF or steroids. In fact, the results were very satisfactory. The graft survival and rejection, the 5-year graft survival was 84%. The 1-year graft survival was 89%, and the complication after 12 and 60 months were minimal with early steroid withdrawal. And this other study showed clearly that in comparing the historical control with the group of patients, whether it is living or diseased, that especially in the living, the graft survival was similar in both groups. This led us to see what guidelines told us about the issue of steroid withdrawal. We suggest that in patients who are at a low immunological risk and who receive induction, corticosteroids could be discontinued during the first week after transplantation. But if prednisolone had been used beyond the first week, we suggest prednisolone to be continued rather than after still this conclusion, still there is few unanswered questions. and this is the European best practice. The same conclusion: steroid withdrawal is safe only in proportion of recipients, and recommend it only in low-risk recipients. The efficiency of the many immunosuppression should be considered. اللي هي مش كل immunosuppressive protocol ينفع ان انا اعمل له steroid withdrawal. Unanswered question: هل السايد افكتس بتاعت 5 ملغ بريدنيزولون لو مشيناها على طول is really it is effective? In fact, the 5 mg prednisolone have no complication compared to the steroid-free protocol. Is there any immune phenotype of high responders that will develop acute or chronic rejection after steroid withdrawal? We don't know. Do we simulate indirect antigen recognition, de novo anti-HLA antibody, or other allo-immune response after steroid withdrawal اللي هي بتبقى responsive مع ديت graft loss? We don't know. Leaving the steroid problem and the recommendation with either too early or leave it with 5 mg, no problem as a complication or cardiovascular complication. The second main issue is CNI minimization or withdrawal strategy and how we can proceed. CNI avoidance, it is the omission of CNI from de novo immunosuppressive regimen, but CNI minimization, that is we use it in reduced doses. الحقيقة عندي 2 studies مهمين قوي وضعوا بوضوح على الكلام. السيمفون ستادي والسيزر ستادي. السيمفون ستادي قالت لي ايه؟ السيمفون ستادي جابت نام نورمال سايكلوسبون وفي اندكشن على فكره MMF والسترويد اللي هي الدان عادي وزود اندكشن. اما جت تغير في البروتوكول حطت اندكشن ولو سايكلوسبون MMF والسترويد، لو تاك MMF والسترويد، ولو سيبورماس MMF والسترويد. والثلاثه الاربعه دول كان فيهم اندكشن، الفوقانيه دي ما كانش فيها اندكشن. النتائج بتاعت ديت افتر فولو اب بعد سنه قالت ايه؟ قال لك انه the biopsy proven acute rejection rate was significantly lower with low dose of tacrolimus than all other groups. اذا قللنا الدوز ما حصلش ريجكشن زائد. طب هل في فايده في الجرافت سرفايفل او الفانكشن؟ الرد هنا قال لك انه في CNI avoidance with low dose of tacrolimus failed to show an improvement in renal function. هي ما عملتش امبروف لكن ما عملتش حاجه وحشه، ده بس نوع امبروف. طب هل عملت حاجه ثانيه في الجراف سرفايفل؟ دي بس الجراف سرفايفل كان موجود في اللو دوز اوف تاكورس. الويزدرول والسايد افكتس الحقيقه كانت عاليه شويه في السيجورماس جروب، لكن ده ربما كان الهاي دوز المستعمله مش اللوزز، ولو ان دي كانت لو دوز. طب السيزر ستادي قالت ايه؟ السيزر ستادي الحقيقه عملت هنا MMF وداكلوزماب وسترويد و18 مانث فولو اب، لقت انه في اللو دوز اوف سايكلوسبورين كان احسن حاجه موجوده. اذا الكونكلوجن من هذا الكلام ان اللو دوز في العيانين بالاختيار المناسب is not wrong so long as your patient is low risk and تستعمل معاها either steroids او other anti-proliferative drug. هل الكلمه بتاعت البعبع اللي بيخوفنا سايكلوسبورين نيفروتوكسيستي is it fact؟ الحقيقه انه سايكلوسبورين نيفروتوكسيستي خدت هذه الباد ريبيوتيشن من الفيري هاي دوزز اللي كانت مستعمله في الاول. واجينست هذا الكلام ابتدى يقولوا نو the late graft loss is not due to nephrotoxicity of CNI but probably the alloimmunity at no CNI is the major cause of failure. ايه الدوكيومنتس او ايه الداتا تسبورت الستمنتس اللي انا بقولها دي؟ قال لك هنا انه الانسنس اوف كرونيك ريجكشن انكريز بايه؟ ان في علاقه بين الكرونيك ريجكشن والاكيوت ريجكشن. وفي علاقه بين inadequate immunosuppression. وفي علاقه بالHLA mismatches. ان الايدنتيكال allografts may survive indefinitely. وفي correlation بين chronic rejection to T cell mediated and humoral autoimmune response والتولرانس بيمنع chronic rejection. ايه تاني؟ قال عندنا دي كاف ستادي 12 سنه 2010 قالت 57 of the patient with chronic graft dysfunction have antibody mediated rejection 7.5 years post from transplantation. الستادي الثانيه 12 في 2011 قالت لك there is arteriolar hyalurosis that has been associated with used CNI was found to a similar extent in transplant recipients who were never exposed to CNI compared to patients treated with CNI. إذا كل الداتا دي بتحط علامات استفهام إنه actually إنه إحنا we are over exaggerating دي الكلمة بتاعت CNI nephrotoxicity. What is about CNI elimination protocol بقى؟ احنا خلاص اقتنعنا ان هي انه ما فيش نيفروتوكسيستي كبيره، لكن in view of the value of mTOR inhibitors في cardiovascular risk والفي malignancy وبتقلل الفيرال انفكشن if there is no risk in using them why we don't start putting them provided proper timing and the proper choice of your patient. عشان اقدر ان انا ما بقاش بيرسونال فيو عندي دلوقتي 4 ستاديز هنا طبعا سترايد وزرول وسورماس have been evaluated in many trials لكن في كلها النتائج كانت ميكسد شويه. عندي كونسبت ترايل وعندي سبيرز نيفرون ترايل وعندي كونفرت ترايل وعندي زيرس ترايل. هنشوف قالوا ايه ونستنتج منهم ايه. الكونسبت ترايل اولا هي النون اميونيزيشن at 3 months هو عمل هنا اليمينيشن بعد 3 اشهر. لكن لما اختار الناس قال لك نون راندمايزيشن يعني استبعد ايه؟ الناس اللي جالها اكيوت ريجكشن والكرياتينين كليرنس اقل من 40 مللي واللي عنده سلال اكثر من 1 جرام واللي بياخد MMF دوز اكثر من 1.5 جرام. This means that he selected from group of patients بليميتيشنز معينه وكاركترستيك اكثر ما يعمل لهم كونفرجن من السيركلوسبون ويديهم السيرولوس. النتيجه انه فعلا بعد سنه لقينا انه جرافت فانكشن كانت احسن في المجموعه اللي خد السيرولوس. ليه؟ لانه كان اختيار كويس واستبعد الناس الريسكي واللي هو عندهم بروتونوريا والجي اف ار اقل من 40 واللي محتاجين هاي دوز اوف immunosuppression guided by the dose of microphenotype. ومش كده الفايده الاكثر ان لقى المالجنسي قليله قوي في هذه العيانين اللي خد السيرولوس. الكونفرت ترايل بقى الكونكلوجنز بتاعتها قال لك كونفرجن واز فيفر في الناس اللي هي جود كيدني فانكشن ونو البومنويا، لكن الناس اللي عندها سيفير رينال دامج شو نوبيفيت ممكن يحصل لها ديتوريشن. الديت to guide us and if you decide to convert do it convert early as possible بس طبعا not before the 3 months الاولانيين بعد ما تضمن انه your graft is stable. What about the Zeus؟ الزيرس عملت نفس الكلام ادت اندكشن وبعد كده عملت كونفرجن وبرضه بعد 6 months. الحقيقه الكونكلوجن انا قلت لك improved the graft function GFR اتحسن ب 9 مللي لتر في المينيت after conversion بعد elimination of CNI واعطاء الفورماس اللي هو السيرتيكال. moreover لا الريجكشن more or less the same. ده اللي هم الكونفرجن. طب if I will minimize and not convert is it useful? Yes. And with استعمال السيرتيكال we allow for halving انك تقلل الدوز اوف CNI in de novo transplantation على 12 months nearly half the dose. يبقى ده اللي انا عاوز اوصل له انه ممكن the certain study showed that we can minimize CNI dose to the half dose with the help of the addition of steroids. وفي حاجة تانية في interaction مهم إن الدوز of سيرتيكان when administered with tacrolimus need to be higher than when administered with cyclosporin لأن الانتراكشن مع السايكلوسبون بيعلي الليفل فلا بد ما تستعمل السايكلوسبون لنقص الدوز. الريزلتس بتاعت السي ان اي elimination قال لك in the concept and the zeus there was better renal function in the CNR withdrawal group. In the spare nephron and the converted trial, no significant improvement in renal function at 2 years after transplantation. وفي study اتنشرت أخيرا اسمها السيرتن ستادي برضه ما وصلتنيش لكونكلوجن إنه فعلا في improvement بالمعنى
يا ماهر الناس كانت وشنا يا ماهر.
اوكي. predictors خلاص فاضل 2 slides. The predictors of success of using immunosuppression عشان تنجح start them early and your patient must have autonomy أقل من 1 جرام GFR عالي ما فيهوش سب كلينيكال ريجكشن يعني تعمل له بايوبسي يعني early stable graft تقدر تعمل elimination وتحط الاميتوز وتاخد فايدتها في الانتي مالجنسي والانتي فايرال سيفتي. conclusion ايه بقى التكنيك وقتنا ايه؟ قال لك we recommend the use of combination of immunosuppressive medication as maintenance therapy including CNI and anti-proliferative agent with or without steroids. We suggest that tacrolimus or cephalosporin to start before or at the time of transplantation. يعني استعملته حتى قبل الترانسبلانتيشن مش غلط. Unless there is delayed graft function. We suggest mycophenolate to be better antiproliferative than other preparations. Patients who are low immunological risk and receive induction اللي احنا قلناها قبل كده steroids could be discontinued after the first week. immunosuppressors when they are used, don't use them in the very early to avoid the problem of surgical wounds and healing. لكن later you can use them safely بشرط الجايد لاينز اللي حطيناها the proper selection ان هو العيان عنده stable graft ما فيهوش subclinical rejection ما عندوش بروتينوريا والكدني function is normal. Thank you.
Thank you, Professor Maher, for this very illustrative lecture. I think we have to, for the sake of time, we have to shift to the second speaker.
The next speaker will be Professor